Hi, Dr. Robin Trotman. I'm an infectious disease doctor and the medical director of infection prevention at CoxHealth. Today I'm going to talk a little bit about some of the confusion, some of the projections for COVID-19, maybe some of the misinformation, and hopefully clarify a lot of questions that I'm receiving from colleagues, patients, people in the community. So first I want to talk about how do we predict what's going to happen with this virus. So you've heard about these models, and we've had people confused because the model predicted there would be X amount of deaths, and maybe we're not seeing that in certain places. But here's what I want people to understand. These are models, and so we use models. We know that models are tools. They're not truth. They're not data. They're not reality. They're just a tool. So what we know is that if our model is off, the beautiful thing is we can always regroup. We can tweak the model. We can change the numbers that inform this model, and we might see our projections mirror what we're seeing in reality. So for instance, the original models that we used that predicted ventilator needs and hospital needs, those models were also informed by our preparedness. So if at the time that the models were calculated, we didn't have the hospital beds or the testing capacity, those models would be off. They would predict a higher death rate because the systems weren't as prepared. So what we know now is our systems are more prepared, and we know that some of the public health interventions that have put in place have really changed the arc or the slope of that model. So I'm going to show you a few ways that these models can change. This is a graph, and it shows the course of time, and these are the number of COVID cases. So when they first did models, the systems weren't prepared. We didn't have good, accurate testing, and we probably underestimated the first cases of when COVID was in the U.S. So we thought maybe that the time started here, and so here's our first cases, and they came up to here, but really maybe that first case was somewhere out here. So as you can see, the slope of this line would maybe have been flatter than if maybe in January, mid-January, we start seeing first cases. Maybe this disease was around a Christmas time in the United States. So that's one assumption that would make the model, the trajectory of the number of cases, look different. The other thing that we want to look at is when they do these models, they start right here and they say, how many cases are we going to have over a certain time? And they give you a line like this, and then they give you a range. And the range might look something like this, and they may say, here's the number of maybe deaths or maybe cases down here. And the model projects this big, wide range, and it's based on those assumptions, like how many people are going to get infected by each individual case. So what happens is public health gets involved. We have good testing. We have preparedness in our hospitals. And what we probably are seeing in reality is a curve that maybe looks something more like this. This is good. This is what we want. Because somewhere in here is a threshold of number of COVID cases and number of deaths where the healthcare systems become overwhelmed. So while the total number of cases over time might be the same as if we saw a big high peak like this, what happens is all of these people are above the capacity of the healthcare system, and they're not going to do as well as if the same number of cases over a prolonged time was our experience. So what we wanted to do was, quote, flatten the curve. So what actually flattened the curve? So why is our actual experience now with the number of cases different than what the models might have projected? So there are a bunch of those reasons. And the basic first reason is this reproductive number, the basic reproductive number, the R naught of the virus. We know based on millions of patient experiences throughout the world that one person usually infects about 2.5 people. So what happens is if public health gets involved and we have a case and they can track those people and they can identify the people that were exposed to this one case, isolate them, then that one person leading to 2.5 stops at that point. And eventually, if you can have all of those contact tracings mitigated and you don't have subsequent infections by isolating those people, then eventually your reproductive number becomes 1, and then you start to see this flat curve where you're not seeing new cases. And that's what happened. Public health did tracings, got those people isolated, and we stopped the ongoing spread in our local community. One other thing that can change the model is our preparedness. So people ask, have we over-prepared? The answer is no. By us preparing, that informs the model and changes the slope of the line, and our projections actually come down. So yes, we're physically prepared, our hospital is prepared, but we also, by being prepared, change the way the model looks. So now people are seeing projections down here instead of projections that were way up here, which were based on the hospitals not being prepared. Things like personal protective equipment, ICU beds, ventilators, all of those things we've stood up, and through our incident command structure, we're ready. We're doing the best we can to galvanize all of our resources. Healthcare workers are informed, they're educated, and they're ready to take care of a surge of patients. And so by factoring that into the calculation, our projections actually look better. The number of predicted deaths actually comes down by us making those preparations. Patient safety is really what's driving this. So until we had our supplies up, we had the healthcare system safe, we had better testing, we really wanted to decrease the amount of things we were doing in our healthcare system. What we can tell you now is that the healthcare system is safe. The prevalence in the community is fairly low. We've taken fairly exhaustive measures to make sure that the environment around the healthcare system is safe. People are going to come into the system with a mask. Your healthcare workers are going to have on a mask. We're going to make sure that people are separated in both time and space, meaning you're not going to be 6 foot from somebody in the waiting room. You might wait in your car until you're called in to see your doctor. The other things are we're cleaning the back room, we're cleaning the waiting rooms, and so the healthcare system is safe now. And we want people to know that we are mindful of the medical consequences of slowing this down, and we want our operations to start back up and rolling. They have to. And so that's what you're going to see here in the next couple of weeks is us resuming some of these procedures, getting people back into the clinics. And I think it's going to be safe. And I think that while we do this, we're going to be monitoring the disease in the community. We're going to know the prevalence. We're going to know how the healthcare system looks in the hospital side. And so we may adjust. There may be periods where we have to back off on some of the things we do. And then we may be able to quiet the disease a little bit and then resume again. So that's what you're going to see over the next few weeks. But now's not the time to relax. We really have to keep our foot on the gas. All of these things that you're doing at home now, the masks in public, washing the hands, being mindful of your surroundings and the people around you, staying home if you're sick, staying out of crowded groups, I can tell you those are the things that are going to keep us in this position right now. But if we let up and we don't continue these intensive public health interventions, we might be back with the potential for these kind of numbers again. Remember, we set the graph down here, and that's where we want to stay. And so it's very important that everybody's mindful that we gave ourselves this luxury, and we do not want to let up.